Hello, Takashi. Hello, Takashi.
Hello.
How you been, Takashi?
Yeah, I've been here. I'm working at some hospital. It's okay. Yeah.
Oh, over the other but yeah, you're welcome to stay as long as you want.
Okay. So from 30 minutes, within 30 minutes, a pediatric
Yeah, pediatric fine.
deformity.
Yeah, deformities. I imagine, kyphosis,
Oh,
lordosis,
okay.
that kind of thing. Did
Correct.
you took pediatric neurosurgery, right?
Yeah, yeah, yeah.
Hey,
Pediatric.
maybe a little refresher course for you.
Okay. Oh, yeah.
Okay, we start in 25 minutes.
Okay. Okay. See that I
See you
prepare
then.
and I'm ready. I'm ready and I'm
Okay,
available.
okay.
See you.
I'll be back.
Okay. I'll be back.
Hello, Sharvin.
Hello, am I audible?
How are you doing?
Good, good. How are you?
Very good. Nice to meet you. I'm John Bennett from Miami.
Nice to meet you, sir.
Okay, there'll be more people as we go along. People tend to come late.
All right.
Okay, do you want to test anything? Do you have any videos or something you're worried about in your presentation?
You do not have any videos in my presentation.
Okay. And you've done Zoom before, obviously.
Yeah.
Yeah. It's hard not to do it nowadays.
Oh, yeah. I think it has become the workhorse of all the online meetings that are going on right now.
Well, there was a Google Hangouts was the predecessor of Zoom. I don't
Yeah,
know. You ever use that?
I have not actually. So I use Google Meet for smaller calls or smaller meetings and conferences, like meeting of say 4 or 5 people.
Uh-huh.
But I have never used a Google Meet for such a for an academic purpose, as so to speak.
Yeah. Okay. Is Amit coming? Amit Jala, Dr. Jala coming?
Unfortunately, no, sir. He is occupied in the outpatient department right now.
Oh, okay.
He's with the patient.
Oh, okay.
So yeah.
Okay.
I thought we would be doing it on next week because I it just skipped my mind. We just had an emergency cauda equina decompression to be done.
Oh, really?
So yeah, good you reminded me. I had just completely forgotten about this.
Oh, okay. I understand. Okay, let's start. There'll be people coming along. Okay.
Yeah.
And you can
So
get
what
on
I'll
with,
do is I'll just
hey, let me
yeah,
introduce
I'll
you first.
just
Let me introduce you first. Okay.
yeah.
And I'll record it. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good morning. It's Dr. John Bennett from Neurosurgical TV. We have the pleasure of having Shaun Shet of Ahmedabad, India. He'll be giving a lecture on, well, he can explain exactly what he's lecturing on. Okay, welcome, Shaun. It's all yours.
Uh, Good morning, everyone who is listening. Good evening from my side of the world. It's 8 p.m. right now. So I'll quickly share my screen. I'll be presenting about transforming deformity correction surgery in the pediatric age group and how my practice has shifted from conventional fluoroscopy to the help of O-arm. I hope my screen is visible.
Perfect.
So, yeah. I'll just give a brief about how we have come up with this topic. Conventionally, all pediatric deformity surgeries, especially in my side of the world or in the developing countries where we do not have access to intraoperative 3D CT guided navigation, it is all done through IITV guidance under fluoroscopy. No matter how complex the curves, how rigid the deformity, or the age of the patient. But with the help of the OARM, how it helps, just going to demonstrate a few cases, which is going to enlighten us how intraoperative 3D navigation transforms deformity correction surgeries. So I'm going to start with a straightforward case first, which is a 17-year-old female who presented with spine deformity, which was noticed by her parents since 2 years, and everything was normal perinatal period and developmental milestones. All her daily activities are normal and the neurology is also normal. She just presented with a painless spinal deformity. And if we go through the x-rays, we can see it is a lanky type 5 curve of the lumbar region and with a fairly balanced sagittal profile, pretty flexible also as seen on the bending and the traction films. And if it was a very straightforward T T10 to L4 fixation. And we use navigation. I mean, navigation is not so much advantage here, except when we cannulate the concave side of the apex, where the pedicles are usually thin and dysplastic, thus helping us, in screw accuracy as well as preventing any pedicle breach, especially on the medial side, leading to nerve root injuries. And the other advantage is we can see the entire correction of the patient with the long film feature of the OARM. So instead of seeing only the spinal, the lumbar and the pelvic region, here I'm able to see right from the bilateral femur head to almost T4, T5, thoracic 4, 5, which helps me to even assess intraorbitally if the T4 pelvic angles and the L1 pelvic angles for a global sagittal balance. And it's a good, reasonably good correction on the AP and the lateral views if we see and compare it with the preoperative films. Now on to the second case, which is a bit tricky. It's an 8-year-old male patient who presented, who had spinal deformity since birth. It was gradually increasing. And the first consultation of the deformity was when they presented with us with this deformity. Again, everything was normal. We could see cafe loose spots. Neurologically, the child was normal as well. The deformity as such is not that grotesque, pretty flexible as well. But then if we see the CT scan, we can see the pedicles are very thin and dysplastic as how it is expected in a neurofibromatosis patient. And especially in the apex, we can see there is hardly a pedicle. And if we measured the pedicles on the CT, the preoperative CT scans on the axial pedicle level cuts, and we saw that the pedicle diameter was hardly 4.5 mm. So to cannulate a 4 mm pedicle with our routine pediatric set is also difficult. It can cause breaches. We can see here. I'm just going to use the pointer. You can see here, if we see this side of the pedicle is hardly present. There's just a rim of bone and making it almost impossible to cannulate that. So what, again, we did was a long fixation. As we know that neurofibromatosis is notorious for pseudoarthrosis if it is not tackled both anteriorly and posteriorly. And here, the intraoperative navigation helps me for an extrapedicular screw placement. We start from, it's like an in-out-in technique. We start from the bone, it's outside the bone, and then again goes inside the vertebral body, thus giving us a good hold of the screws. Again, post-operatively, if you see, it was a fairly reasonable correction of the deformity. There is, it can be argued that why such a long fixation? But as I said, because we did not go anteriorly in a child, we did not want to open the thorax and the abdomen, that make it a diaphragm cutting approach. We just went long to prevent implant loosening and implant failure. And again, very reasonable correction, especially in the AP view, we can see the child is doing pretty well. We also added, if you appreciate, we also added artificial bone graft here, calcium triphosphate granules, just to enhance fusion rates. Again, now this case is of a congenital kyphoscoliosis, an 8-year-old female who had deformity since birth. It is pretty common, especially in our country, that the children who have deformity since birth, they present very late, because one, it is lack of awareness whether what to do about it. Second, they are not consulting the right doctors, and they keep on prolonging even evaluation and commencement of treatment, early treatment like brace protocols. So usually they have big deformities at an early stage. And so this was a similar kind where the patient had normal daily activities and normal neurology. But if you see, it was a pretty severe deformity as seen on the AP views, pretty rigid as well for such a young age. At an 8 years of age, we can see there is severe kyphosis, there is a severe scoliotic deformity, and it is not budging even under traction views. So again, we can see here the concave pedicles are very dysplastic because of the severe rotation of the vertebra and the thin dysplastic nature of the pedicles. This is where it again helps us to get a good screw length in all the pedicles, allows us a good angulation. We can also see how the spinal canal is widened. So even a slightest breach can cause neural injury there. So this was another case where we did an osteotomy with a long fixation, osteotomy of the apex with some periapical pontes to aid in the flexibility of the spine. And we did it in 2 stages, as it was a young child We did not want to cause, as we know, an osteotomy causes a lot of bleeding and blood loss. So in the first stage, what we did was we just cannulated the proximal half, and the distal half was the screw entries were made, and we did not put any screws so that you know the track stays. And in the second stage, this is what was done, that we have put the cage at the osteotomy level, compressed nicely with two rods at the apex, and the long rod which act as a neutralization rod and hold the deformity correction in place. And again, so now this case again is of a congenital one, a 12-year-old female who again had deformity since birth. The thing here is that she had undergone a previous surgery in her early childhood. She had gone a cord detethering surgery with the excision of a bony spur, which was done by a neurosurgeon, which was an uneventful procedure. And after that, everything was normal, but then she presented with a severe kyphotic deformity. Uh, as as you can see on the CT scan, which is a pretty acute curve. You see, it's just an acute deformity of 106 degrees, which is pretty severe. It is a huge deformity at the apex. Luckily, the patient did not have any long tract signs or any spinal cord issues, because usually what we see is if patients like this who have an acute curve of kyphosis, they present with either a spinal cord edema or myelopathy because of the stretching of the cord over the internal gibbous, as we call. So again, what we did was we put screws at the apex. I'm sorry, at the upper and the lower ends of the deformity, and we know we are cannulating the other levels. We can see how deformed the vertebral body is. There is widening of the spinal canal with hardly any pedicle present. And it also guided us with the level of the angle of the osteotomy that is required. We could see with the navigated probe that is the instrument here. And it helped us in assessing the amount of bone that needs to be required. It also helps us to see if there is any internal bone which is impinging on the spinal cord as we correct the kyphosis, which usually causes, sometimes it causes a loss of the neuromonitoring signals, and puts additional stress or puts tension on the surgeon. So, and we got a good correction of the kyphosis. We did an osteotomy at that level. A good hold of the pedicle screws thanks to the navigation. There was no screw malposition. Good correction. If you see, this entire part was removed and it was filled with the graft. And nicely, the curve of the kyphotic curve of the rod is going along smoothly with the spine as compared to an acute curve here. So this is how it has transformed the practice of deformity surgery, because as we know, in a deformity correction surgery, when we apply correct deformity corrective forces on the screws are under tremendous stress, especially in rigid curves. As we know, we have special reduction rods. The rod is translated, it pulls. There is CAD, where there is concave apical translation, there is convex derotation. A lot of maneuvers occurring at the same time, which put a lot of stress on the screws. And if we don't target the screws properly, especially in the upper and the lower instrumented vertebra, which make the base of your construct, then the screw hold is not that great to withstand these forces, leading to either a screw pull out or screw just there's a breach of either of the cortices, and it leads to uh, under correction of the deformity, or you expect uh, the deformity to be corrected to a certain extent, and then it does not get corrected because the screw hold is not that great. So especially in the pediatric age group where the pedicles are dysplastic more so on the concave side, and the pedicles are already thin. And the last thing we want is to injure the spinal cord or the nerve, leading to neurological complications, which is pretty highly recorded, especially in even the younger age group of the pediatric deformity. So I would say this helps a lot. There is an argument that we can do this without navigation. We have been doing this without navigations almost since the past, like in my spine surgery training as well as after it. We have been using navigation in the past 2 years. So before that, it was all done freehand. There was a reasonable correction, but there is always a doubt, especially in such cases, whether your screw is right or wrong, and whether the correction maneuver with hold the deformity correction in place. So this is where navigation has changed and transformed our pediatric deformity correction practice, especially for us. Uh, Thank you.
Thank you very much. I don't have any questions. I was paying attention, televising it and promoting it. Any panelists have any comments or questions? Wait a minute, are you done?
Yep, I'm done with the presentation. I'll just stop
Okay,
the screen share when you tell me.
okay, so you're done, right?
Yes.
Yeah, so thank you for the presentation. Let me see it from the panelists. Does anybody have any comments or questions from the panel? Perhaps not. It's a quiet audience. Well, Doc, I appreciate you taking the time from your day, your busy day, to present. And this will be viewed on our channel and YouTube after we edit it, so you can put it in your video resume. Okay?
Got it.
Okay, thank you very much. I'll send you the link.
Thank you, sir. We'll be in touch.
Okay, bye-bye.
Bye.